Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast today. Welcome to August. My name is Terry Fletcher. It's crazy how summer is just flying on by. Today is our 93rd episode, so we are going to try to focus and keep my podcast under 30 minutes. I know I've been going a little bit long lately. Apparently, I've got a lot to say, but I'm going to keep this one short and sweet today. At least I'm going to attempt to. I always try to do a 30-minute threshold, and sometimes I'm around 20, 25 minutes, and sometimes I've gone up to as much as 37 minutes or higher. But I know a lot of you listen to this on your way to work or home from work, and I just want to make sure that I don't lose you during most of it. So we're going to try and keep our time threshold on track today. And also because I want to get outside and enjoy the rest of my weekend, because you know I do pre-record these, I want to go ahead and get started. So our topic today comes from a question I received from the editor of Part B News magazine. So I'm a contributor for them quite a bit because I do a lot of work with Decision Health. And the writer wanted me to comment for an article he was writing on physician late signatures. And I think what's interesting about some of the topics that I present here on the CodeCast is the fact that we even need to talk about it. So when a compliance issue comes up, meaning not following the published guidelines, then we have to talk about it. And your credibility and your reimbursement and your reputation as a physician and as a practice comes into play when you see some of these topics that I present, such as the one on critical care, the one on how to document time, and just things not followed. And so today we're going to really talk about that physician late signatures, meaning that they're authenticating a record after it's already been billed or even before it's been sent out, but after the date of service. And that's a problem. And then also I have a second part of today that there is I guess you'd call it a compliance issue, but I was reading the Australia Journal of Medicine, and the concept they're talking about, when I bring it to your attention, you're going to be like, oh my gosh, I can't believe some of the most basic ideas contribute in such a big way to patient safety and outcomes. So the second half of the show, you'll hopefully see an idea that isn't too small and isn't too trivial to make a difference in the healthcare field, or any field for that matter. And so if you ever have any kind of insight that you want to share with your employer, you should, because it's amazing to me. You could think they're just minuscule or, unimportant things that you want to bring up, but you'd be surprised how important they can be in the big scheme of things. And I'm going to kind of share what that is with you after a bit. So the first thing we want to talk about, again, is our late signatures. So the question that came in was, Terry, I have a question about late signatures on documentation. So I've been hearing about providers signing their notes a very long time after the encounter, weeks later, sometimes even months later, and even sometimes turning them in unassigned on an ADR. So let me just explain what an ADR is real quick. So medical review additional development requests, those are called ADR process. So when a claim is selected for medical review from a Medicare payer, a medical review for additional development request, that's the MRADR, is generated requesting medical documentation be submitted to ensure payment is appropriate. Basically, they're asking you to prove medical necessity before we pay you. It's almost like a prepayment review. Documentation has to be received within 45 calendar days for review and payment determination. And then why do they do this ADR? Well, whenever the payer, and I know CGS and Noridian are big proponents of this, they can select a medical review and generate an ADR. And basically, they're trying to make sure that claims, when elements on the claim basically match the parameters of a prepayment audit suggested by the payer, or additional information about certain types of edits that look like they're going to be part of this encounter, they can actually generate that. So now what he's asking me, this writer from Decision Health and Part B News, is he's saying that even when they're asking for additional information, they're not signing their record. So, CMS guidance has said that they're really not supposed to do that. But I'm told, and actually this writer also told me within his email, that when auditors catch it, as a rule, they generally just let the provider attest to it and let it go, their signature. Well, not this auditor. If I don't have an authenticated or signed record, that is one of the basics of Medicare documentation. So his question was, how does this really work? And, he feels that a super late signature, which I don't know if that's a technical term, but he says he feels that's fraud. Well, I don't like to use the F word in anything I talk about unless there's intent. A lot of times I think that it's just physicians, providers of any kind, getting lazy in being compliant in the medical record. And so we have to make sure that we are efficient and not just letting it go. And this is a question I get a lot. And so it's a compliance issue for sure. The surrounding rules for the signature on a note come from the general documentation guidelines. So the main concern, and this is one I often hear from billing staff, relating to the timely completion of medical records, is about making sure that the record is closed out and authenticated before it is sent to the payer. So in many of the webinars and webcasts and seminars that I attend and I actually also present, here's some of the information that Medicare constantly talks about, and they actually put it in their Chapter 12 of their manual as well. So it says, first of all, the medical record should be complete and legible. Well, EMR is taking care of the legible thing. Complete's another story. Number 2, the documentation of each patient encounter should include the reason for the encounter and the relevant patient history, physical exam findings and prior diagnostic test results, assessment and clinical impressions or diagnoses, a plan for care, and the last bullet is a date and legible identity of the observer. So when you fail on any level there of the documentation guidelines, you're going to have a problem because, again, why the issue of legibility, that's been addressed and increased utilization of electronic health records, completion of the record through the inclusion of proper documentation and signed, dated with signatures still is a concern. So what does it mean for a medical record to be complete? First of all, is the record complete when it contains the documentation of the patient encounter but is not signed and dated? So as you know, you should not bill for an office visit or other service until documentation on file supporting the level of service indicated for billing is complete. The file is not complete until the proper documentation is accompanied by a dated signature. So now the question becomes, how long do you have to sign and date the record in order for it to be accepted by Medicare? So the question is most important because the EMR or EHR system that you're using, and a lot of the ones that I work with, do not allow you to backdate the signatures, which thank God. So as I'm auditing, I know exactly when the physician's signature was actually authenticated or when it was actually performed or entered into the system. And so the question always comes up, how long is too long after the care is provided to put in that signature? Because I have to talk to the administrator about this, that it's time-stamped. If you go to the website of the Medicare carrier, so Medicare Administrative Contractor, you might find the answer. So the policy manual is kind of vague when it talks about this as far as how soon are they supposed to document your signature or sign the note. And so and also timing can vary from region to region. But here's what CMS says, and this is a quote from the Chapter 12 of the manual. It says, the service should be documented during or as soon as practicable after it is provided in order to maintain an accurate medical record, meaning that they do not want the physician to forget details by waiting to sign off on the note. Also, some payers have put on their websites their own interpretation or what they enforce. Some give reasonable direction, like WPS Medicare. This is in Illinois, in Wisconsin, which states a reasonable expectation would be no more than a couple of days away from the service itself. I wish they would have been a little bit more technical, like giving the exact hours. A couple of days seems so lay terms. Noridian, and that's what we have here in California, and this is one of the biggest MACs in the country. They state, and they're specific, in most states, or in most cases, the notes would be signed at the time services are rendered. And Palmetto's a little bit more direct. They say providers should not add a late signature to the medical record beyond the short delay that occurs during the transcription process. It is understood that there are circumstances like waiting for transcription to be complete that might preclude signing the record at the time of service. But in general, it is best to sign the record at the time of the service, not within a day or two at the latest. If not within a day or two at the latest. I also educate my clients that signatures beyond a couple of days increase the likelihood that a claim will be denied because medically necessary documentation will not be accepted as being present due to the signature and date too removed from the time the care was provided. And this is really costly in an audit. So, for example, if every note that had a signature older than 3 days after a service was provided was not accepted by your MAC carrier, then the provider's documentation of work that was done at the time of the visit would also not be allowed. As a result, there would be no accepted documentation for the visit, and then they'd ask for refunds, and they would not even give you any payment at all if you receive one, because an attestation statement basically saying what was done was also added at a later date. So I have a kind of a general rule for my clients, or they don't need to be my clients. And maybe this seems a little bit harsh, but this is what keeps my clients and anyone who's a potential client, and hopefully those of you on the CodeCast are actually enforcing this as well in your practice. I make sure that my clients know that I enforce a policy that holds all of their providers in their offices and clinics to a standard time period of not more than 36 hours to have a signature on the chart. And I'm really strict about it. And actually, I think I'm giving them quite a bit of leeway with 3 days. If they do not want to adhere to the policy, I drop them as a client. So I have to be able to support and appeal to any record that is questioned. And without mandatory policies like this, it can give physicians too much rope to basically hang themselves out to dry. And accountability is key. So it's probably more information that you wanted than on this topic, and it sounds like I'm angry today, which I'm not, just so you know. But this is a topic that drives me crazy, because to me, it's common sense. Sign your note, authenticate your note. And so that's where it's been a problem. The response I got back from Rob on this, he said, "This is absolutely great, Terry, clear and thorough. Are you planning to podcast on this? Because I think you've just written the script." Well, guess what? Yes, I'm podcasting on that. And he also said, "I hear what you're saying about the max." He also noticed that Noridian recently added, "Further delays may require an explanation." And he's like, this is hilariously vague, because you can just see a doctor basically sitting there and saying, okay, why didn't I sign this? And so I've been involved in several audits where all the documentation was actually adequate, but it wasn't signed. And so it was awful, because if it's not signed, you've got a problem, and this can lead to huge compliance issues. Okay, so the next thing I want to get to, and this one is kind of amusing to me, but before that, the CodeCast is also brought to you today by Stranger Things, netflix.com/Stranger Things, and Victoria Selman Amazon and New York Times bestselling author. Check out Blood for Blood and Nothing to Lose, VictoriaSelmanAuthor.com. Also find her as a co-host on Crime Girl Gang, True Crime podcast on iTunes and YouTube. I think it's really funny that I'm getting all these true crime podcasts sponsoring my show. I'm kind of liking it, actually. It gives us a little bit of an edge, don't you think? And my shout outs this week, before I get into the second part, we're looking at hello to Yolanda and Marla Ray, Greta, Jennifer, Eric, and ARIC, Jean Gordy, Tony, and Ruth. Ruth, I finally got your name. And so just really appreciate all of you, and on all of my social media platforms, saying hi or giving me some positive feedback. So another thing that came up, and this is from the Journal of Medical Association from Australia. So there was a doctor that made a decision in a surgical room, and so in an OR, that he decided to put his name on his scrub cap. And it's actually changing safety in hospitals around the world, not just in the United States. And so when I was reading this article, it basically was talking about, we get so used to our everyday lives, we rarely stop to question just the simple things. So after all, if they remain the same for so long, how do you even know how you can improve them even more? Well, in an attempt to avoid confusion during some surgical operations, there was an Australian anesthetist, Dr. Rob Hackett. He decided to wear a scrub cap with his name on it, Rob Anesthetist. And everybody was like, "Did you forget your name?" And he put it in big letters. And the hashtag Theater Cap Challenge is an initiative from the Patient Safe Network in response to concerns about how easily avoidable mistakes and poor communication are contributing to rising adverse events for patients in the hospital setting. So this has been adopted around the world now, and just in the last 3 to 4 months, with studies from the US and UK demonstrating how this simple idea can decrease human errors in healthcare. So think about this. So there was a lot of snide remarks and everything, basically saying, why do you feel like you need to put your cap on? Well, the reason is that there's an argument that having the names on their head cap, the cloth ones, can save vital seconds in life and death situations. So basically, you can reduce delays and misidentification that occur when clinicians can't recognize or can't remember the names of their colleagues, and they call it in the operating theater. That's why it's called the theater cap challenge. But the one physician was saying that he went to a cardiac arrest patient in a surgical suite, he called it his theater, where there were 20 people in the room. And he said, I struggled to even ask to be passed some gloves because the person I was pointing to thought I was pointing to the person behind them. And so he said it's so much easier when you can coordinate, when you know everyone's name and their role within a surgical unit. And it also is creating some camaraderie, and it's great for patients as well. But the thing that's interesting is that the UK did some studies, and they've shown increased name recall among staff from 42 to 85% increased name and role introductions during this surgical safety checklist by doing some of these things, and how it also increased the efficiency. And they said, first of all, when it comes to patients, especially women who are having cesarean sections in particular, they're benefiting from reassurance of knowing the names and positions of every staff member around them. They're also now getting into reusable caps, not just the paper ones, because they call it again a 20 theater hospital. I swear, those people over in Great Britain, we love you, but boy, you call things some funny things. But they said a 20 theater hospital will discard over 100,000 disposable caps every year, and caps are made from viscose, which is a substance whose production is particularly harmful to the environment. So now they're trying to have them cloth so that they wash them and give them back to somebody. But a hospital of that size also could spend somewhere in $10,000s of dollars every year on disposable caps as well. But the operating rooms and the World Health Organization safety checklist that now has adopted this as well, they've tried to put in a requirement that requires all staff to introduce themselves prior to surgery. And the reason that this is important, because it was never enforced, is that this section of the checklist was usually disregarded. And so when it's done properly, and some people are laughing in the operating room, you can tell that it's not done regularly if they're, kind of laughing about it. But you have to know who's in command, who's doing what, because if you don't know who the person is that's providing certain services, that can hurt people, possibly even kill people. As somebody who has to get her hours for nursing in a surgical setting every 2 years, I've noticed that sometimes I will be observing instead of actually assisting in a surgery, and the surgeon will look up, this is the one who weren't participating in this, and they'll look at somebody who basically is an intern or a tech or an anesthetist and ask for an instrument when it's not their job. And so they'll just look at them like, what are you talking about? So then they'll go to the assistant surgeon or the person who's actually assisting in the procedure and say, is it you? And they spend so much time trying to figure out who's actually in that OR setting that it just becomes such a problem. So it's really important that, everyone remember, it's kind of like, hello, my name is, and introduce themselves, but to have that on their actual hat or their surgical, helmet, whatever you want to call it, it's really important to not only the patients, but just think of the efficiency now in there from that little thing. Just put your name on your hat and make sure that on your scrub hat, that your cap, I guess it is, that it can save patients' lives, because the doctor or the surgeon only has to look up now, see who it is, make a comment, and say, I need this, and it's all good. So something that trivial or that little, believe it or not, can make a difference. And so if you have ideas about that in your office, just like I talked about with professionalism and waiting room changes and just little things, you want to bring it to your practice attention. Even something as turning up or down the thermostat 1 degree is going to make a difference. Things like that make a difference. Okay, so my personal tidbit this week, it has been brought to my attention, thank you, Tony, that you may not be aware of a service that I offer that regards personal business coaching. So I've received an inquiry this past week from a CodeCast listener, and yes, this is a service I do provide. Since then, I've had that inquiry. I've had 3 people ask me the same thing. I think you're all anticipating my Business Collective podcast. So thank you for those who have asked and contacted me directly. And I've also now engaged my services. So if you are interested in that service, yes, it is a fee for service. So contact me on pricing. But if you need to know and have questions on how to venture out on your own, I'm happy to offer you coaching advice, services, insight, some tools just to get started. I have over 32 years in the business of healthcare, and being on my own as an entrepreneur for the last 22, I've made every mistake possible, corrected those mistakes with better choices, and I really have an understanding of the process, probably better than anyone I know. So just keep one thing in mind. I do try to keep things positive, but there's going to be some things in business that you may not like to hear. So you need to listen to all of it. The only way to really understand and learn is to listen and hear what's being said, reflect on it, write down some questions you have, and then come back to it again for more detail and insight. And then you'll end up deciding if you really want to work for yourself, and it'll all be worth it. And so I hope you trust me on this and really, kind of engage if you're interested. It's really a great service that I started doing a few years back, and I get an occasional person here and there, and it's really picked up lately. So thank you again for anybody who's asked about that. I just want to make sure that we've given you the insight there. So that's a wrap for this episode, everyone. Make it a great day. And until next time, thank you for listening to the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.